Good afternoon, everyone, and thank you so much for joining us today for a press briefing discussing recent clinical and preclinical advances in focused ultrasound. I'm Jessica Foley, Chief Scientific Officer for the Focused Ultrasound Foundation, and I will be moderating today's discussion. Today, you will be hearing from many experts in the field of focused ultrasound, including Dr. Nir Lipsman from Sunnybrook Health Sciences Center in Toronto, Canada, who will be discussing recent advances in treating brain tumors with focused ultrasound. Dr. Jose Obeso of the Centro Integral de Neurociencias in Madrid, Spain, who will talk about the use of focused ultrasound to halt the progression of Parkinson's disease. Dr. Aaron Kim from Children's National Hospital in Washington, D.C., who is discussing promising new pediatric oncologic applications for focused ultrasound. Dr. Lynn Dengel from the University of Virginia in Charlottesville, Virginia, who will talk about the use of focused ultrasound plus immunotherapy drugs to treat advanced solid tumors, including metastatic breast cancer. Dr. Reese Cosgrove of Brigham and Women's Hospital in Boston, Massachusetts, who will discuss the treatment of psychiatric disorders with focused ultrasound. And Nobel laureate Dr. James Allison of the MD Anderson Cancer Center in Houston, Texas, an expert in the field of cancer immunotherapy. I'd like to briefly go over a few housekeeping items, and then we'll jump into the pre-recorded presentations, followed by a live question and answer session with our panelists. If your connection is lost, please simply log in again through the link you received when you registered, and you will receive a link to a recording of the webinar as well. If you'd like to ask a question, please submit it at any time via the Q&A function at the bottom of your screen. We will collect these questions until the Q&A period at the end of the presentation. And now I'd like to start the presentation portion of our program. We will begin with a comment from Dr. James Allison about the promise of focused ultrasound technology in the field of cancer immunotherapy. Please note that Dr. Allison will also be talking in much greater detail about this topic on Tuesday, November 10th at approximately 9:30 a.m. as one of our symposium's keynote speakers, and we encourage you all to tune in to his session to learn more. You can register for the symposium at symposium.fusfoundation.org. Registration is free and the meeting is entirely virtual. Now, please enjoy the presentations that our panelists have put together for you, and I will be back immediately following Dr. Cosgrove's talk to field questions live with our speakers. Thank you.
So one of the promising combinations that can be done with immunotherapy, are different techniques of radiation. We've been seeing really amazingly good responses in metastatic disease by radiation or cryoablation or whatever with single metastases that a person with, in patients or animals mostly, with multiple tumors. And I think that as focused ultrasound progresses in the clinic, there's hope and some promise, good promise, that can also be a modality. We're just killing just enough tumor cells not to be curative by itself, but to prime an immune response by releasing antigens, causing some inflammation, and starting this whole wonderful process that leads to elaboration of T cells, which can come in and finish the job, and providing the long-lived immunity that can cure patients, hopefully.
Thanks very much for joining. First of all, I'd like to thank the Focused Ultrasound Foundation for organizing this event and this terrific panel, which I'm privileged and honored to be a part of. My name is Nir Lipsman. I'm a neurosurgeon at Sunnybrook Health Sciences Center at the University of Toronto, and I'm happy to discuss our experiences on focused ultrasound and neuro-oncology, where we are now and what next steps could be. So focused ultrasound is a rapidly growing field. Specifically, when you look at publications dealing with brain focused ultrasound, when we've looked at this, there's an exponential rise of interest. So this is publications per year over the last 30 or so years, and you can see that research is exponentially increasing with the publication in the field approximately every day or two coming out. So this is a rapidly growing area. And a lot of that has to do with the myriad ways that focused ultrasound can interact with the brain. So the ones most frequently that we are referring to are high frequency focused ultrasound to generate a lesion in the brain, or low frequency ultrasound, where we can combine ultrasound energy with microscopically injected microbubbles so that we can enhance the delivery of compounds across the temporarily open blood-brain barrier. But there are other ways that focused ultrasound can interact with the brain, and many of these have significant implications for oncology. These can include temporary or transient modulation of brain circuitry, histotripsy, which is very fine, specific, spatially accurate lesioning, targeted uncaging of nanodroplets for drug delivery, and hyperthermia, potentially as a means to enhance radiation therapy or other kinds of things for brain tumors. So not only can we use ultrasound to image, we can also potentially use it as a therapeutic modality in a whole bunch of different ways. And in oncology, and this is particularly relevant, and specifically to deal with potentially lesions like the one that you see here on the left, glioblastoma multiforme, which is the most common kind of malignant and aggressive brain cancer, where although we've learned a lot about the genetic profile and how this tumor behaves under a microscope for several decades, we haven't really had a lot of appreciable changes in survival and in progression-free survival and in limiting and preventing the decline that these patients have. So any strategy, any treatment that can potentially move the dial will be significantly impactful. But one of the problems is the blood-brain barrier. And for the last several decades, different technologies have tried to overcome the blood-brain barrier, this idea that there exists this barrier that prevents potentially useful compounds from gaining access to the brain to treat the things we want to treat. And in the context of tumors, we've done things like inserted catheters, inserted chemotherapy, impregnated polymer systems, microchips, as well as tried molecular mimicry approaches to fool the blood-brain barrier into allowing the passage of certain compounds. But all of these have their respective limitations, whether it's cost or whether it's the risk associated with them. So a way to, in a very focal and a very safe and precise way, bypassing the blood-brain barrier has been a major goal for the field. So this is how focused ultrasound can potentially help. So the idea is that ultrasound is energy, sound energy, that is applied through the intact skull onto discrete parts of the brain. Now, when patients are injected with microscopic microbubbles, so a contrast agent contains microbubbles shown here in red, when those microbubbles are exposed to focused ultrasound energy, they can oscillate, they can increase and decrease in size very, very quickly. And that leads to a physical pulling apart of the cells comprising the blood-brain barrier, such that whatever is circulating at the same time as that blood-brain barrier is open will go through those opened up cells of the blood-brain barrier and gain access to the brain in concentrations that ordinarily would not be permitted because of the intact blood-brain barrier. So the idea is that this is a physical, mechanical process that opens up the blood-brain barrier and does so reversibly. So the blood-brain barrier ultimately is reconstituted or closed within hours of it opening. So this could be a kind of window onto pathology in the brain that will allow us to gain access and deliver the kind of therapies we want to get into the brain. So we work with Psychiatric, and this is the machine that we use at Sunnybrook at the University of Toronto. It's the machine known as Exablate, manufactured again by Psychiatric, and there are several key features of this device. This can include, for example, the fact that we use a stereotactic frame to keep the patient's head still during the procedure. We do it with real-time neuroimaging, so we can see exactly what it is that we're doing in the brain with a real-time 3 Tesla MRI. We use 1,024 transducers that we can individually steer onto discrete regions of the brain. And we do as much as we can to minimize interference by introducing cooled, degassed water between the patient's head and the ultrasound transducers. And all of this is to achieve what we call a stereotactic, which is really anatomically, spatially, and temporally precise image-guided means of accessing brain pathology. So in the context of glioblastoma, we opened the blood-brain barrier for the first time in a human patient back in 2015 and published our first experience in a first-in-human trial in 2019. And this is what this looked like back then. So this is a patient that had a right frontal brain tumor resected. And immediately behind that resection cavity, you can see that we've opened the blood-brain barrier here. And this fluffy white material is contrast agent, it's gadolinium, that only goes to parts of the brain where the blood-brain barrier is either disrupted or open. And you can see that it's for several centimeters behind this previously resected tumor, the blood-brain barrier has been opened. So this area is exposed to much larger concentrations of chemotherapy than it would ordinarily be exposed to. So since the phase 1 trial, much of the technology has evolved. We're now able to treat much larger volumes, and significant software upgrades developed by Insightec and the company has allowed us to really see in real time, potentially, the blood-brain barrier being open. And this is what it looks like in the phase 2 trial that we're currently running here at Sunnybrook, and this is a trial also being run at other centers around the world. So the goal of this phase 2 trial was really to better define and characterize the safety profile of opening the blood-brain barrier in much larger volumes and in larger number of patients. And this is exactly what you see here. So this is an axial view, cross-sectional view of a brain tumor. And this kind of heat map around this tumor that we're targeting is not temperature, it's not heat, it's an indirect measure of microbubble activity, and in a way, an indirect measure of opening of the blood-brain barrier. And what we've now done is we've shown that we can actually do this in very large volume, in much larger volumes than we showed even in our first trial. So we can open at least 30 cubic centimeters of blood-brain barrier opening. We do this in a procedure that with patients awake, it's non-invasive. In the vast majority of patients go home, in the vast majority of situations, the patients go home on the same day. So this is a day procedure where patients come in the morning and they leave about an hour to 2 hours after the procedure is complete. And the actual treatment time is approximately 2 to 3 hours. So this is really the first time that non-invasive day surgery opening of a blood-brain barrier to enhance the delivery of chemotherapy has been done in large volumes. This is an example of one of our patients. I showed the MRI earlier, so here you can see an example of a right temporal glioblastoma multiforme. This is what it looks like after it has been resected. This is what the treatment looks like after the first focused ultrasound session. And again, we are combining focused ultrasound with temozolomide, which is a kind of chemotherapy that is a standard of care for patients who undergo glioblastoma treatment. And here you can see that the resection cavity has essentially been made to fluoresce with gadolinium because of the blood-brain barrier opening. And this is what the tumor looked like at 6 months after 6 completed treatments of focused ultrasound. And 6 months after that, so 12 months after the patient started the trial, we can see a significant reduction in size of the area of the resection cavity. Another area that we're quite interested in is metastatic tumors to the brain, specifically breast cancer metastases to the brain. So this is a condition where there are effective chemotherapies to treat all non-brain lesions. So these may be patients, for example, who have exquisitely controlled systemic disease. So the disease may be very well controlled everywhere except the head, but they have ongoing brain metastases that threaten their quality of life and ultimately their survival. So the goal here is to use focused ultrasound to open the blood-brain barrier to enhance the delivery of a chemotherapy. So in this case, it's a chemotherapy known as Herceptin, also known as trastuzumab. And again, this is a very effective medication for treating breast cancer metastases everywhere except in the brain. Because Herceptin is a very large compound. It's several orders of magnitude larger than the typical drug that can get into the brain. So we really want to enhance its delivery to the brain. So this are the first 2 patients that we've treated, and you can see both of these lesions here are in the back part of the brain, the part of the brain known as the cerebellum. And what we were able to show in both of these patients is that we can safely and reversibly open the blood-brain barrier. We can do it in regions of the brain that are really exquisitely very what we call eloquent, very sensitive regions of the brain, at the level of the brainstem and the medulla, near the ventricle, where there are a lot of important blood vessels, and near cranial nerve nuclei, which are very sensitive nerves that control a lot of our face and our neck function. So we were able to show that we can open the blood-brain barrier in those regions. The next step is to continue this trial in more patients, combine focused ultrasound with other kinds of chemotherapy, and potentially an exciting aspect of this trial is to label the chemotherapy with a small radioligand so that we can actually visualize the passage of the chemotherapy into the brain. So that work is now ongoing. Another potential exciting application of ultrasound to neuro-oncology is the idea of using the technology as a kind of liquid biopsy. So why is that important? Why would it be important, for example, to detect the signatures of pathology peripherally, for example, in a blood test? Well, this is an MRI, but one such example. So this tumor in the center of the brain can either be something that needs to be surgically resected with a fairly risky operation, or it can be something that can undergo either chemotherapy, radiation therapy, and to significant positive effect. But in order to get that information, one would need a biopsy, and the biopsy itself would require inherently some risk. So a means of opening up the blood-brain barrier and potentially allowing us to detect peripherally what this lesion could be by taking a blood test, for example, could significantly lead to a potentially more promising way of making diagnoses for these kinds of lesions. So the idea is, can focused ultrasound help? And we're at the very early stages of answering that question. And what we're now detecting is that when we open the blood-brain barrier with focused ultrasound, we're detecting a significant increase in the detection of what we call cell-free DNA immediately after the procedure. The amount of cell-free DNA also increases the more times and the greater volume of blood-brain barrier that you're actually able to open. And the cell-free DNA, or cfDNA, is the basic substrate that you need on which you can run the necessary test to allow you to distinguish whether, in fact, it is a tumor and whether you can determine what kind of tumor it may be. So we're actually able to open a window into the brain or into this pathology, detect the resulting tissue peripherally with a blood test, and hopefully one day run the test that will allow us to make a definitive diagnosis. So that may indeed obviate or mitigate the need of an open neurosurgical approach exclusively for the purpose of biopsy. So what are the next steps in cancer? There are many, and the application of focused ultrasound to oncology are arguably its most exciting in many respects. So we're interested in developing this treatment, as are many centers around the world, for primary brain tumors, whether it's glioblastoma, other high-grade malignant astrocytomas, and other lesions such as subependymal giant cell astrocytomas. We're interested in seeing its application specifically of chemotherapy and targeted immunotherapy and targeted chemotherapy approaches to secondary or metastatic brain tumors, whether it's in breast, lung, or melanoma. And we're very interested in working with our pediatric colleagues on developing applications in children, specifically in diffuse intrinsic pontine gliomas, which are devastating and malignant illnesses occurring in the brainstem of pediatric patients, for which there is intense interest, but so far very little available in terms of therapeutic strategy. So this may indeed be a potential option down the road. So for all of these, we're also interested in using focused ultrasound upfront, so at diagnosis, during maintenance chemotherapy, and also at recurrence. So for all of these conditions, there is a time when they're diagnosed, when they're treated, and ultimately when they recur. So focused ultrasound can potentially be used at all of these junctures. So what is the goal? The goal is basically to turn this table green. So everything green here are studies that are currently ongoing. You can see that in glioblastoma, maintenance and recurrent tumors, those trials are ongoing. And in the realm of Herceptin and delivering Herceptin to the brain in the context of breast cancer, there are several trials in development and some that are indeed starting soon. So the goal over the next 5 years, 5 to 10 years, I would say, is to really fill this table green and to run as many trials as we can to really develop these trials and these protocols in parallel so that we can have as many tools under our belt to battle these conditions as we can. So the world of focused ultrasound is rapidly expanding, as we've seen from an academic perspective, with research coming out nearly every day with focused ultrasound in the brain. What we're also seeing is the development of many indications and many centers coming up from around the world. So this is arguably, I would say, one of the most exciting, one of the most promising areas in the clinical neurosciences, with growth that is significant and exponential. With that, I'll conclude and want to thank once more the Focused Ultrasound Foundation for inviting me to speak and to be a member of this panel. I'm happy to address any questions.
Good afternoon. Pleasure to be here and trying to summarize to you our current studies and ideas about how to treat neurodegeneration by using focused ultrasound, and particularly in my case, Parkinson's disease. So in Parkinson's disease, there is a fundamental abnormality, which is that the dopamine neurons, typically in the substantia nigra pars compacta, they die, they degenerate, and there is a loss of the connection between the dopamine nigra cells with the target in the striatum, particularly in the putamen nucleus of these two structures, and that is responsible for most of the typical manifestations of Parkinson's disease, like the slowness, the rigidity, the tremor, etc. And this is associated with a number of changes in circuits. See here, this sketch or cartoon shows the nigra compacta, the putamen, and connections in different pathways which fire back to the cortex to facilitate movement, which is one of the major functions of this structure. When there is a severe dopamine depletion here, as secondary to the cell loss, then there are a number of changes following that dopamine depletion. A very important one is that the subthalamic nucleus, which is a structure which is just above the nigra, a little bit lateral to the nigra, becomes dysfunctional, and the neurons are activated in a wrong way, particularly in a way which leads the cortex to be inhibited or stop, and therefore there is the normal flowing of neuronal activity to facilitate actions. The decision to act and to perform is reduced, if not blocked, up to really not being able to move at all. So in Parkinson's disease, we are now able to do two things. One, to try to restore towards normality this dysfunction, and then perhaps to deliver drugs or agents to attack the disease process. And this can be achieved with focused ultrasound, by high frequency focused ultrasound, which allows to produce focal ablation of dysfunctional structures like the subthalamic nucleus, or by opening the blood-brain barrier to facilitate delivery. Important to understand that in Parkinson's disease, the onset, when the diagnosis is made in the large majority of patients, the manifestations are really very focal. And as you can see in this person, there is almost no arm swinging in this affected arm and upper limb, while the arm swinging is normal in the other. When he tries to shrug his shoulders, the left is normal, the right barely move. And when he tries to use his hands and the fingers, the left is normal and the right is really very slow and almost a stop. And all that is mediated by abnormal activity of the subthalamic nucleus, which keeps firing wrong signals to the cortex, which do not allow the person to move normally, as you can see here. So in the scheme here, we have the cortex, which should send the right messages to the spinal cord and muscles. We have dopamine depletion in the putamen and striatum, which leads to abnormal subthalamic nucleus activity. And our goal currently is to stop this abnormal neuronal activity here, to cause a restoration of this abnormal circuit activity, and improve symptomatically the Parkinson's major symptoms, and then achieve a sort of a free period or better period of evolution, which could go for 5-10 years. We have shown in the past that doing this focal ablation, the subthalamic nucleus, this was published in Lancet Neurology 3 years ago. We can see this enormous improvement in the contralateral, the treated side in 10 patients, so treated in an open trial. And recently we did a double-blind randomized study in conjunction with University of Virginia in the USA, and you see that the sham-treated arm improved very little, only 15.5%, while the FUS subthalamotomy induced lesion produced a major improvement, highly significant, and this will be published soon. Thinking in the real neurodegeneration process, we know that, as shown by neuroimaging, that uptake is reduced early in early PD, very focally in the posterior putamen. Here you see a horizontal cut of the brain. This is anterior, posterior, and lateral, and this would be the side contralateral in the person who we saw the video a little bit earlier on. In that particular person, it was the right upper limb, and this is the left putamen, and you can see very striking dopamine depletion focally in this motor region of the putamen. So we know the depletion begins here, and then with progression will extend anteriorly in this side, and will start here, which is far behind here, and then will extend also anteriorly. And this can be pictured in this sagittal or also coronal views or axial. This is coronal, this is axial, to see that this is the area where dopamine depletion is maximal, and perhaps where it is really beginning early in the disease. And this corresponds more or less to the proximal upper limb, more or less to the forearm shoulder region of the body. So they could be our target to do blood-brain barrier opening by giving this bubble material intravenously, then giving the sonication, the ultrasound delivery, and this will facilitate these gap junctions opening in the blood-brain barrier, which could allow then the passage of putative neurorestorative drugs. We're doing very actively, we're very engaged in BBB opening using non-human primate as preclinical research. And here you see a major, massive opening in one putamen in the subject or here. And we had followed now to do this in patients. And here you see some initial finding of opening. This is nothing nearly as good as we have been obtaining in the non-human primate, but this is just a matter of methodology to be improved. We did get a very good result with BBB opening in the cortex in people with PD dementia. Parkinson's disease is the second cause of dementia in neurodegenerative dementia worldwide. And so Parkinson's dementia is also a very important unmet need to try to tackle. And BBB opening could also be an opportunity to deliver restorative agents like antibodies against the synuclein protein in the cortex. We did this in 5 patients in 10 treatment sessions, emulating in a way the experience in Toronto and in New York, Penn State University in Alzheimer's disease. So here you see the putamen, and you see another better case of PD patient with posterior putamen targeted. And eventually we should be able to deliver agents like gene therapy, etc., in that particular region to try to modify the progression of Parkinson's disease. And that's what we are at in my center in the south of Madrid. Thank you very much.
Thank you so much for the invitation to speak today. Today, I'll be discussing promising new pediatric oncologic applications for Focused Ultrasound. We've made a lot of strides in pediatric cancer, with now more than 80% of our patients being long-term survivors of pediatric cancer. However, this has come at a significant cost. The acute and late effects of current multimodal therapy in children are substantial. And this success has not been equally distributed among pediatric cancers, and the prognosis for metastatic recurrent solid tumors is dismal and has not improved over the past 3 decades. We still need to continue to improve our current therapeutic paradigms for pediatric cancer. One of the ways and goals that we think about this is precision therapy. And this is really to identify targets with the goal of optimizing efficacy and decreasing toxicity. And one of the prime ways we think about this is tumor genomic sequencing to identify actionable mutations and coming up with drugs to target those actionable mutations. However, advances in imaging and tumor localization, allowing for non-invasive therapies and novel drug delivery mechanisms, is also a way of thinking about precision therapy. At Children's National, we have the Image-Guided Non-Invasive Therapeutic Energy Team, or IGNITE team. This is a truly multidisciplinary team consisting of interventional radiologists, oncologists, bioengineers, surgeons, radiologists, and anesthesiologists. And our vision is to develop and clinically translate focused ultrasound through targeted approaches to minimize side effects and increase efficacy to improve the care of pediatric patients with cancer. So truly thinking about precision therapy. So what are the advantages of focused ultrasound? Well, it's non-invasive, there's no radiation, there's image guidance for precision and accuracy, multiple bioeffects with the flexibility to be combined with other applications and treatments, and thus far well tolerated with minimal, minor, reversible side effects. And all these characteristics really make it ideal for the development of, ideal for its development in pediatric cancer. So back in 2015, our image-guided, non-invasive therapeutic energy team, our IGNITE team, opened the first pediatric clinical trial of MR HIFU in the US for painful osteoid osteomas in children. And this was led by Dr. Sharma to determine the safety and feasibility of MR HIFU for painful osteoid osteomas in children. This was subsequently followed by a clinical trial of MR HIFU for the ablation of pediatric solid tumors to determine the safety and tolerability of MR HIFU in children with relapsed refractory primary or metastatic solid tumors. And what did we learn about HIFU ablation application? So we learned that MR HIFU ablation of osteoid osteomas and solid tumors appears to be safe and feasible. The majority of osteomas had complete responses and durable pain relief, and this was published in the Journal of Pediatrics back in 2017. And osteomas are benign tumors that really have the location and size that really makes it ideal for HIFU ablation applications. However, the majority of solid tumors that we've seen can only be partially ablated due to its size and location. These are much more invasive tumors, much larger, and much more difficult to reach. In addition, many lesions are not targetable, including those that are metastatic in the lungs, and how to target multiple metastatic lesions is also a challenge. And when we think about pediatric cancer therapy, we really do need to think about entire treatment in order to achieve long-term cure. So we have to think about HIFU applications in combination with smarter therapy and in combination with immunotherapy. So the next clinical trial that we developed was a phase 1 trial of MR HIFU with LTLD for pediatric solid tumors. So LTLD, or Thermodox, is a heat-activated formulation of liposomal doxorubicin, which is a chemotherapy that is often used for many pediatric cancers. It allows for release of systemically administered encapsulated doxorubicin with heating and allows for the rapid drug release in the heated targeted tumor vasculature, thus allowing for concentrations of doxorubicin otherwise not achievable through systemic administration. These results are too early to state. However, HIFU ablation with LTLD may overcome some of the limitations that we discussed about ablation in terms of peri-ablation zone therapy and incomplete treatment, but it still doesn't address that tumors are still not targetable and that some tumors still are located in metastatic sites that are not reachable. So then we think about HIFU and immunotherapy for pediatric cancers. There's growing evidence of modulation of adaptive and innate immunity through HIFU, through changes in cellular immune response, modification of tumor antigenicity, and upregulation of heat shock proteins. And we know that pediatric cancers are typically considered non-immunogenic. And one way to think about it is how do we make them immunogenic? So we had a preclinical mouse neuroblastoma study of HIFU in combination with checkpoint inhibitors. And we use HIFU as in form of histotripsy in combination with these checkpoint inhibitors. And only in combination and not either alone with HIFU or alone with checkpoint inhibitors did we see prolonged survival. And we also saw that this combination caused significant intratumoral infiltration of macrophages and helper T cells. And we're also evaluating these in other disease models, including a rhabdomyosarcoma model with HIFU ablation and HIFU histotripsy at this time. In addition, we're looking to expand HIFU in the neuroscience applications and expanding for the brain systems based on the same principles that we've used thinking about focused ultrasound applications for pediatric cancers. We're collaborating with our neurosurgeons, our interventional neuroradiologists, and our neuro-oncologists to look at different mechanisms of HIFU and neuroscience applications, including FUS disruption of the blood-brain barrier, FUS and immunomodulation for brain tumors, FUS and sensitization to chemoradiation, and FUS-mediated drug delivery for pediatric brain tumors. So in summary, Focused Ultrasound is a team science and really requires a multidisciplinary approach for pediatric cancer. We think that Focused Ultrasound has a potential to replace current local control mechanisms. However, there are limitations, and really the current and future for most pediatric cancer application is combinatorial approaches using the various bioeffects of Focused Ultrasound. We have ongoing preclinical and clinical applications that really have the potential to change treatment paradigms in pediatric cancer medicine. With that, thank you so much, and I'll take any questions.
I'm happy to be here today to talk about our investigative study of focused ultrasound ablation as a mechanism to enhance systemic immune therapy in advanced solid tumors. There's been great recent success in immunotherapy through T-cell checkpoint blockade, adaptive T-cell transfer, and vaccination immune therapy. The response rates, though, remain low, from 20 to 40%. And we know that patients who have increased T-cell infiltration at their tumor sites do better. Tumors escape the immune system by altering the microenvironment at the tumor, limiting the success of our immunotherapy. They prevent penetration of immune cells and block immune activation signals, upregulating PD-1 ligand to induce T-cell exhaustion and constraining CD8 T-cell cytotoxic anti-tumor response. Focused ultrasound is a potential mechanism to counter this tumor inhibition of the immune response. By using focused ultrasound at the tumor site, we can potentially increase antigen release, leading to further antigen capture and presentation at the lymph nodes, increasing priming and activation, leading to greater circulating tumor-specific T cells. And back at the tumor site, focused ultrasound can create an environment which is more permeable, increasing T cell infiltration and proliferation. When we designed our focused ultrasound ablation protocol, we specifically aimed to optimize for the secondary zone. When you ablate the tumor, there is a primary ablation zone that's created. This is a higher heat area with coagulative necrosis. But surrounding this primary zone, there's a secondary zone that actually has a lower heat stress and creates a more immunologically favorable environment. So in our protocol, we use a single course of treatment over only a 5 to 10 millimeter diameter area, with the goal of applying the treatment to 33% of the estimated tumor volume. We found in our center there's a clinical need for durable responses in a larger percent of patients. In our study of advanced solid tumors, which includes melanoma, we're specifically aiming to offer this to participants who are non-responders to anti-PD-1 treatment at 12 weeks. Standard of care, these patients would remain on PD-1 therapy. However, their expected response would be low at about 10% with this ongoing treatment alone. We also sought to serve patients with low expected rate of response to PD-1 therapy alone up front, such as patients with uveal melanoma, and patients who decline, discontinue, or are just not eligible for PD-1 blockade. We selected PD-1 blockade as our systemic therapy option as we have extensive experience at our center with this as the first choice as a single agent for melanoma. It has a relatively lower toxicity profile compared to anti-CTLA-4 therapy. It's approved for multiple malignancies, which we hoped would improve our trial enrollment and recruitment. And there's a potential synergistic effect on T cells when combined with focused ultrasound. In addition, at our university, there is a second trial similarly combining systemic PD-1 therapy with focused ultrasound. This is in patients with metastatic breast cancer being offered by Drs. Dillon, Brennan, and Bullock. Breast cancer is an immune privilege and typically evades the immune system. PD-1 blockade is approved in triple-negative breast cancer, but the response rate is only 20%. This trial seeks to serve patients with metastatic or unresectable breast cancer who failed at least one prior therapy. The endpoints of the trials include safety and toxicity, and the primary immunologic endpoint is to look at CD8 T-cell infiltration in treated and untreated metastasis when that's available. Additionally, we will include endpoints such as investigation of the tumor microenvironment, characterization of circulating T-cell population, and looking at the clinical response in treated and untreated metastases. Our advanced solid tumor trial is open and successfully enrolling. We've enrolled 3 of 32 participants, which have been treated without immediate toxicity. Participant 1 had metastatic colon cancer to the bilateral inguinal lymph nodes, and we performed focused ultrasound of a left inguinal node. You can see here with our treatment planning emphasizing the goal to treat only a small portion of the tumor. The upper blocked spots are the treatment sites, and the lower part of the tumor is left untreated. After treatment, we see the echogenic foci at the site of tumor ablation. And following, our biopsies were performed both pre and post of the secondary zone, not the primary ablative zone. This trial is open and successfully enrolling, and we've treated 3 patients so far, 1 with the inguinal node, 1 in the axillary node, and 1 with an abdominal mass. And this supports ongoing enrollment, data analysis, and we're hopeful that this trial will provide pilot data to drive future research in this arena. The trial for patients with metastatic breast cancer, offering PD-1 and focused ultrasound with investigators Dillon, Brennan, and Bullock, has also opened to enrollment and successfully enrolled 10 patients. The mean prior therapies has been 4.4, and receptor status has been mixed, with 5 ER positive, 3 HER2 positive, and 1 triple negative. Side effects so far have been mild pain at the ablation site, fatigue, nausea, and dyspnea. We'd like to thank the many collaborators in research and our research team who've made these trials possible, and of course our patients too. And we're happy to be here and thank the Focused Ultrasound Foundation for their support and the opportunity to share this work.
So today I've been asked to speak with you about the possible role of focused ultrasound in the treatment of psychiatric disease. And to begin with, I should give you my disclosures. I am indeed a consultant for Psychiatric, one of the companies that makes a focused ultrasound device, and I do receive clinical trial research funding from them for trials unrelated to this presentation. But my true confession is that I still love the stereotactic frame, which is a versatile neurosurgical instrument for performing functional neurosurgery. And it actually, something similar is used in focused ultrasound procedures. But any discussion about surgery for psychiatric disease is always controversial. In large part, it's because of its rather dark history. When it was performed probably overzealously and sometimes inappropriately, using very crude instrumentation. As you can see here in the upper image, this was as a representation of the so-called prefrontal lobotomy, where blunt instruments are inserted into the frontal lobes of patients to alter their behavior and thoughts. If there was one man that we might consider more responsible for the demise of surgery for psychiatric disease, it's this man in the lower image, Walter Freeman, who was not a neurosurgeon, but a neurologist and psychiatrist who was the champion of psychiatric surgery in the United States for many years. And here you see him performing one of his more infamous ice pick procedures, which similarly damaged the inferior portions of the frontal lobe for psychiatric indications. Because of this history, there's certainly a lack of acceptance in the lay community, as well as in institutions and in the medical community, especially in psychiatry, because rightfully so, people were discussing how could damaging the brain cause any sort of improvement in thoughts or feelings or emotions. Another area for controversy, and a reason for controversy, is the fact that we still don't have a clear neurobiologic understanding of these disorders. I think we all accept the fact that these are not disorders of one part of the brain, but This is a circuit disorder, much as we understand Parkinson's disease and tremor as a circuit disorder. But neuropsychiatric disorders are certainly much more complex. And we are just beginning to understand some of the areas of the brain involved in these disorders. Using the Human Connectome Project and resting state functional MRI images I've displayed here may help us better understand what the basis of these diseases are in the human brain. And finally, there's really no class 1 evidence for surgical intervention. There's a lot of class 2 and class 3 type of evidence that it's useful in certain psychiatric diseases, but there's certainly no class 1 evidence. What has been my personal experience? Well, I have performed this kind of surgery for almost 30 years. This is very different from the surgery performed in the 40s and 50s and 60s. This is all performed with modern MRI-guided stereotactic techniques where we can very accurately and successfully place lesions in certain targets within the brain. All of these procedures, I've done probably a little over 100 of these cases over 30 years. So it's not a busy practice in this, and it's always been done with institutional and IRB approval, and only in those patients who have failed all conventional medical therapies and behavioral therapies and ECT. So what are the different procedures? I'm just going to show you some pictures. This is an image of an acute cingulotomy. So these are lesions in the anterior cingulum, which we know is involved in emotional processing, combined with a lesion here in the subcaudate region, in the posterior orbital frontal cortex. This is a limbic leucotomy. I've also performed both radiofrequency and gamma knife capsulotomies, also a procedure performed for mostly patients with obsessive compulsive disorder. And I've also been involved in cases with deep brain stimulation. Deep brain stimulation is chronic electrical stimulation of the same targets that we have used for ablation, but instead of ablating the tissue, we stimulate it at high frequency with electrical current. So what have I learned from this experience? Well, as a neurosurgeon, I'm very familiar with physical suffering, but the mental suffering in these patients and their families is immense and enduring. I can say that surgery is only performed as an intervention of last resort, but it can be effective in a substantial portion of otherwise untreatable cases. It's somewhere between about 2/3 of people will get a favorable result and improvement in their psychiatric burden. The clinical benefit is always delayed and it's never complete. There are no cures in these disorders, but interestingly enough, the benefit improves over time. And obviously, we need a better understanding of the neurocircuitry and neurobiology of these disorders if we're going to be continue to do this in the future and be more successful at it. And so finally, there is so much more to learn and a lot more work to be done. And you could ask, is there really a need for novel interventions? Well, think about it. Major depressive disorder in this country is felt to represent maybe 5 to 8% of the population. So this is recurrent major depression. And probably 10 to 20% of those patients are completely refractory. Obsessive compulsive disorder is a much smaller prevalence, maybe 1, maybe 2% of the population, but it's a harder disease to treat. and probably 10% are severe and incapacitating. And then you only have to think about addiction, a pervasive disorder, made much worse more recently with the access to narcotics and heroin, and think about the deaths related to that. And certainly there are other neuropsychiatric disorders such as anorexia and PTSD. So I do believe there is a need for novel interventions. And then the final question I'll pose is, can focused ultrasound fill that need? And if so, how? So the first and most obvious approach would be to consider duplicating and replicating some of the benefits that we've seen with standard open stereotactic ablation of the targets that we've used in the past for the last 40 or 50 years. The beauty of focused ultrasound is that it's completely non-invasive, so that there's no risk of bleeding or hemorrhage or infection. So there's no operative risks. There's a possibility that we can, instead of permanently ablating targets in the brain, that we could reversibly explore new targets in the brain with sublethal focused ultrasound application. Certainly using lower frequency devices, 220 hertz devices, this can now modulate neuronal activity, and we could apply focal neuromodulation in nodes in the circuits that we feel are implicated in the different disorders. And finally, we can use the same kind of technology to open up the blood-brain barrier in those areas potentially, and apply or infuse selective biologic agents that could either enhance or alter the neuronal function in the nodes in the circuit. So these are just some of the possibilities that lie ahead. And I will close by simply saying that there really is so much more to learn, and there's a lot of work to do in the future. So thank you very much.
So thank you all for those wonderful presentations. I wanted to encourage those online to continue to send in your questions. We have quite probably about half an hour or so for questions and answers. So please do continue to send in those questions. But I'll start off with something that I did want to bring up that has happened since the recording of these presentations, and that this is directed to Doctors Obeso and Lipsman. So you recently we've recently had some announcements around your capability of addressing the treatment of Parkinson's disease with the focus of placing focused ultrasound in the striatum. And so I wanted to give you an opportunity to talk about those clinical trials that you have ongoing, really what the significance is of being able to target that area of the brain, and the next steps you have in your respective clinical trials. So could we start with Dr. Obeso?
Thank you very much, Jessica. Yes, indeed. Like in the world of Alzheimer's, BBB opening can certainly has place in Parkinson's disease for the same basic mechanism and reasons. So we initially went to mimic somewhat what is going on in Alzheimer's, and did 5 patients with Parkinson's disease dementia. And we did open the BBB in the parieto-temporal occipital junction 10 times. Those patients with Parkinson's disease dementia are not like Alzheimer's, but they are demented. And in fact, having Parkinson's disease gives the highest risk of developing dementia in the general population. So it's really an unmet need. But we realized that the actual therapeutic target for Parkinson's disease, particularly because focused ultrasounds allows us to do early, very precocious intervention. So the real target is the putamen, the striatum, where dopamine depletion begins, and it spreads from the back part of the striatum to rostrally, and then it spreads somewhere else. So if we could stop the degeneration process at the very beginning of PD, that would be a real undertaking and achievement, and would turn extremely good for the patient. Therefore, we are focusing nowadays with focused ultrasound in the putamen, which is our primary target. And we have done so far 7 patients in whom we open particularly the posterior part, the postcommissural part of the putamen. In the initial 3 patients, we did it unilaterally 2 times. And then in the second part of the study, we have done it bilaterally in the patients in the same session. Because obviously PD dopamine depletion is bilateral, very asymmetrical, but is bilateral. So if one has a good therapeutic deliverable, one probably could go bilaterally since the very beginning. So the significance of this is that it shows to do the opening in the putamen of PD patient is feasible and seems safe with a precaution of a still relatively low N. Nevertheless, absolutely nothing negative has happened. If anything, patients and relatives and the attending clinicians, we all believe there is some modest but striking improvement in a number of clinical features. So what is next? The next thing is to deliver a real restorative, some molecule which could act against the degeneration. And the big question here is, what can we deliver which is allowable, which is permissive by the authorities, and that is viable. And this is our real important challenge at this moment.
Thank you. Thank you, Jessica, and also to the FUS Foundation for organizing this event. And I don't have much to add more to Professor Obeso's terrific summary of.
You can add what you are doing, which is very relevant.
Yeah, absolutely. No, we are. We too have a trial in Toronto at Sunnybrook on opening the blood-brain barrier in patients with PD, where we're targeting similarly the striatum and putamen in these patients. I think that it's critical to highlight a few things. One, as Dr. Obeso said, I think it's important as a field that we first establish safety and feasibility in these patients, not only from a clinical perspective that the patient is well tolerated and we don't see any adverse events or minimal of adverse events. But also that, from a feasibility and tolerability perspective, that patients are able to tolerate the procedure. These are serial procedures. So in our trial, we target, again, unilateral putamen striatum 3 times every 2 weeks. We are delivering a therapeutic. In this case, we're delivering glucose cerebrosidase, or GCase, in these patients. There are some genetic subtypes of Parkinson's disease. One of the most common genetic mutations is related to GBA gene, where patients with, given the link between Gaucher's disease and Parkinson's disease genetically in some patients, there, as a result, has been the idea that, if you enhance the delivery of enzymes, of these kinds of enzymes to the brain, you may see potential effects. Again, all of this is part and parcel with the pursuit of disease-modifying therapies for Parkinson's. And I echo strongly Dr. Obeso's point about establishing first safety and efficacy, and then moving on as a community to determining in more patients what ought to be the therapeutic that we should deliver. And that's where sort of the stakeholders need to come together and really determine what the most promising therapeutic would be. Now, I don't think we should have just a single trial and single efforts. I think that, we ought to go in parallel I think there are many potential therapeutics that we could look at, and I think that's where the FUS Foundation and other stakeholders can really be involved with helping us choose and helping move the field forward.
Great, thank you. I wanted to ask you, Nir, before we move on, can you also elaborate a bit on your current work in the area of opening the blood-brain barrier with focused ultrasound for the purpose of liquid biopsy?
Sure. So, one of the areas, one of the powers of ultrasound potentially is its use not only as obviously as a therapeutic tool where you can use it to generate lesions, as we saw, but also to open the BBB and deliver therapeutic as a medium or a delivery strategy. But we, as well as many other groups, are interested in in diagnostic potential, and specifically in the ability to liberate disease markers, whether it's fragments of DNA, whether it's fragments of cells, or other kinds of biomarkers that we may be able to pick up peripherally after we've opened the blood-brain barrier. And this really spans the spectrum from oncologic applications, where the idea is to enrich plasma or blood with cell-free DNA, which is sort of the building blocks on which you'll be able to potentially make a diagnosis or hone in on a diagnosis, or other potential markers that may exist that may be of interest. So there, the possibility is not only to make a diagnosis, but to guide treatment and to track treatment, see how things potentially evolve over time. So still very much early days, but again, along the same theme of using ultrasound to mitigate or obviate the need for open cranial approaches for some kinds of pathology, and even some kinds of pathology for which surgery may not even be required. So things like Alzheimer's and Parkinson's down the road. So I think it's a promising strategy, and one where, again, would require close collaboration between industry as well as academic centers to try to develop these high throughput technologies.
Great. So sticking with the brain for just a bit, Dr. Cosgrove, obviously you've talked about a lot of different ways that focused ultrasound could be used in treating different psychiatric disorders. Obviously, given the current time that we're in with COVID-19, we're seeing a lot more increased mental illness due to isolation, sickness, all of that. So I'm just curious if you could elaborate on focused ultrasound's potential role in treating mood disorders that could in fact be scenarios that people are facing today. Dr. Cosgrove, are you still with us? All right. Okay, maybe not.
Let me just quickly say on this,
sure, yeah,
Jessica, that psychiatric disorders, as was pointed out very clearly in the last lecture, can be understood as a disorder of a circuitry on brain areas, and more complex and more difficult to define, and that's the problem. But once you can define a particular mechanism and a circuitry associated with, let's say, depression, which is the better known, but also obsessive compulsive disorder, for instance, then these are accessible to be interfered with or modulated or deliver a given substance which will somehow modify for the better the neuronal activity underlying such behavioral disarray or mood disorder.
I agree.
The problem is, sorry, go on.
Completely. I think that point is excellent. And, following up also on what Dr. Cosgrove was saying in his talk, we perform these procedures in Toronto as well. And, the idea is that capsulotomy, is a neurosurgical procedure, has been done in neurosurgery now for several decades. It's been done since, 50s and 60s and the dawn of the stereotactic era. And now what we have is the ability to potentially, do the same procedure, but in a new way, in a safer way, in a more image-guided way, in a way that is able to limit the size of the lesion that is made and potentially the peripheral and collateral damage associated with making large lesions where a lot of the side effects of previous procedures probably came into play. So I think what ultrasound allows us to do is kind of lower the threshold for surgical referral or for referral to a neuromodulation center, or the ability to do these procedures. That the threshold is lowered. And it's not only, changing perceptions about these interventions in the, amongst clinicians and psychiatrists and neurosurgeons, but also amongst patients. It really validates a circuit-based therapy or circuit-based origin of these diseases, which necessitates and requires a circuit-based therapy. So the idea is that you can generate lesions in the brain with focused ultrasound, and what you're doing is affecting brain-wide networks as a result of doing that. So I think that, for multiple reasons, this has really changed our understanding, not only of the phenomenology, but the semiology of the disease, but also how we treat it.
Thank you for that. So Dr. Dingle, I wondered if you could elaborate a bit more on where you see focused ultrasound fitting into the overall toolbox for treating different cancers, advanced cancers, and specifically if you could elaborate on the ability of, really what you see as the ability of focused ultrasound to add strength to a combination approach with the checkpoint inhibitors.
Absolutely. I'm happy to. Thank you. I think to first start, of course, like so many other have said, our first goal is to prove safety. And so, as we do that, we can then start to think about how can we expand the indication. Right now, we're really focused on patients who have very few, if any, other options for treatment, because of course that justifies doing the trial procedure in those settings. But as we get data from our current trials and from other institutions, it would be great to be able to expand that to a broader group of patients, potentially in a neoadjuvant setting. If patients are getting checkpoint blockade, for instance, in melanoma that's borderline resectable, you could possibly add a focused ultrasound treatment there to bolster that immune response preoperatively. So, I think there's a much broader patient population that could benefit from this once we demonstrate safety. We had quite a bit of a challenge getting this trial through regulatory protocols, and I'm very hopeful, as we've only treated 3 patients so far, but they've all gone very well. I think one really important thing to note is when we treat these patients in our protocol, because we're aiming to really create that secondary zone and not just ablate them, it's a very quick procedure and really well tolerated, because there's only a few foci of treatment. And so patients are getting a lot less sedation versus, for instance, in our institution prior, we were doing just fibroadenomas and ablated the whole lesion. Now it's a lot shorter of a treatment. It's less painful. They require less intervention, really minimal sedation. So when you look at a protocol like that doesn't take as much time or add much morbidity or risk, you can expand it to other patient populations who are getting immunotherapy to, hopefully open up that space, change the tumor microenvironment, and support and even improve upon immunotherapy in the types of cancer where expected response is 20 or 30%.
Great, thank you. So, Dr. Kim, it's kind of a similar question to you on where you sort of ultimately see focused ultrasound fitting into your overall toolbox for treating pediatric oncologic patients. And then also kind of, if you could speak to that, and then also if you could speak a little bit more about some of the interesting collaborations that you mentioned, for example, in using focused ultrasound in combination with drug delivery.
I echo a lot of what the speakers have already spoken about in terms of combinatorial approaches. So in pediatric cancer, we've thought about thinking about focused ultrasound first, with a lower hanging fruit of using the ablation technology as a local control mechanism, which I think works great for smaller sized tumors. We were able to successfully treat a small sarcoma with that and stayed sustained for quite some time. But for many of our malignant cancers, we've discovered that they are too large or they're metastatic. They have the potential for complete ablation is not feasible due to size and location. So I think that's where this really combination approach takes place. And whether that combination is with drug delivery mechanisms, such as something like thermodox or other types of, I think, novel therapeutics that may be out there, or a combination with immune therapy. And as Dr. Dangle had mentioned, some of our preclinical studies show that only a small amount of either mechanical disruption or ablation is actually required in order to kind of trigger that immune response in the murine models. And that's what we hope for if we can translate that into the clinical setting. So we know that the majority of our pediatric cancers have not seen the success of the immune therapy checkpoint inhibitors as many of the adult cancers have. And part of that we think is because they're typically not considered immunogenic or they're cold. And so the thought is, can we make them immunogenic? Can we make them hot through these combination approaches? I think there are so many potential applications. So not only with immune therapy and other types of drug delivery mechanisms, but really this kind of adjuvant therapy where focused ultrasound can enhance or give additional treatment towards pediatric cancer is really an exciting and novel way to think about things.
Great, thank you. So Dr. Cosgrove, we had a bit of a quick discussion. I wanted to ask you though, given the current state with COVID-19 and there's so much more increased mental illness, wondered if you could elaborate on focused ultrasound's potential role in treating mood disorders.
The only time we would consider, intervening typically surgically, no matter what we do, for mood disorders or the chronic anxiety disorders is if it's very severe and unrelenting and completely intractable. So hopefully the mood disorders and the anxiety that we're feeling around COVID is not going to be intractable or long lasting. It's more a reaction to a situation. But I think the huge advantage of focused ultrasound in at least possibly duplicating some of the procedures we performed in the past and they're still being performed is that it can be done completely non-invasively. And so when we've performed surgery for severe and unrelenting psychiatric diseases, mainly OCD and depression, it's always in the worst cases that have failed everything else, but we still have to instrument the brain and create lesions or place electrodes more recently. So we're operating on the brain to try and improve its function, at least in or mood. And whenever we do that, there's always risks associated with it. And I think and we don't know how much injury or damage is done to the brain when we actually physically instrument it. And so the advantage of focused ultrasound is that we can, as people have, I think Dr. Kim already said, the low-hanging fruit is to duplicate some of our experience that we have with ablative surgery, stereotactic surgery for both mood and OCD. And we can do that without having to open the brain, so that none of the standard risks are there. That doesn't mean that this kind of surgery is without risk, but none of the standard surgical risks are there. And I think that that may allow more people to consider it rather than either having radiofrequency lesions made or having permanently implanted DBS hardware. So I think that's just in the thermal sort of ablative realm. I think as people have already mentioned, that's just the beginning. That's the easy thing to reproduce, and it's the appropriate thing to do first. But I think more importantly is what the future might hold, where we could target areas, zones in the brain that we know are implicated in emotional circuitry, and maybe not ablate, but modulate, either with low intensity focused ultrasound, that's just a completely new field, or opening up blood-brain barrier to put in selective biologic agents. Those are the two areas that I think where most of the work will come, probably not immediately, but that's where I think the future lies.
Thank you. And that's really interesting as we're sort of thinking about these on the horizon, different mechanisms of action from focused ultrasound in the brain and elsewhere in the body, particularly in combination with other therapies. I wanted to now just give you all sort of the opportunity, look into the future. What do you feel in your respective fields are the biggest opportunities for focused ultrasound? And also, what are the obstacles that you think focused ultrasound is facing to really kind of get to widespread clinical adoption? So does anyone want to go first with that? Otherwise, I'll point to someone.
I can start. So I think I already kind of talked about where I think the future applications can be in terms of combinatorial approaches. I think some of the obstacles that we face, especially in pediatrics, some of the regulatory hurdles, I hope that we can continue to think of, pediatrics and age and to be thought about in terms of drug development or device development, that we still think about our younger populations when we're developing and writing clinical trials. I think some of the other limitations is availability of the instruments itself in terms of where this is applicable in the country and who's going to, a lot of this is so experienced, I think user driven as well. And so I think the more it becomes readily available to other sites and centers, the more it can be readily applicable to other patients as well.
Thank you. Lynn, do you have any comments?
I think with Dr. Kim, I build on that and say that that the obstacles in terms of regulatory processing was really much more than we would have expected to get our trial through, and just took so much longer, and really ended up narrowing down the locations we were able to apply focused ultrasound to the metastatic tumor sites. And there aren't clear defined boundaries. We had to create our own table of safety margins that we had to, get support and prove to all the regulatory bodies that we were being safe enough. And so it seemed to me that the requirements as far as proving safety went beyond what any of the clinical practitioners or the experts in focused ultrasound thought was reasonable, and narrowed down the patient population that we were able to enroll in this trial. So I think we really need to prove efficacy and prove really how far do we need to be from critical structures, and how, so that we can broaden the utilization across different aspects of the human anatomy. Would be really helpful in terms of expanding the use.
Mm-hmm.
Jessica, I'm a neurosurgeon, so I only operate in the brain. And yeah, well, Jose is too, but so my obstacles are more pedantic, of course, and I agree with the regulatory obstacles, of course, but that's pervasive. Mine are more, the need for a complete head shave. While it's not horrible in men, it's not so good in women. The need to actually, at least for functional neurosurgical procedures, certainly to put a frame on, and affix a frame. Maybe that won't be as necessary if we're opening up larger regions for blood-brain barrier opening. We could target it in a different way. The need for an expanded treatment volume, that's efficacious treatment volume, so that we're not limited, at least in the functional stereotactic procedures. Dr. Abeso is nodding his head because he knows that when he tries to get out into the putamen, it's just harder to do. So I think there's need for additional engineering expertise and development to be able to make the tool that at least I use even that much more useful. And I think the future is just about to begin, because we're seeing now little titillating experiences with, as Dr. Abeso was showing and others, opening up the blood-brain barrier. And then if you can open that up in a broader region, and you could actually infuse a selective biologic agent, boy, that changes things. And then there's the whole field of focused regional neuromodulation, non-invasively, which those are the two areas that I see the future expanding in, while we continue our work with duplicating some of the easier to understand ablative experience in the brain.
Yeah, let me just jump in. I agree entirely with the need for a further technological, methodological improvement. For ablations also, there is a lot of room for improving. It seems that the current possibilities of the world of imaging and processing of signaling is not yet well applied to focused ultrasound. So a lot to improve there. However, in having said this and agreeing on this, my real concern, what really worries me all the time, because I deal with neurodegenerations, mainly with PD and Huntington's, etc., is really how to know that a given potential therapy has a real good chance to be effective. To begin with, we don't know yet for certain that what Nir and his colleagues in Toronto are delivering to the putamen is actually reaching there in the concentration that we all hope it does, but we don't know. We don't know basic aspects of how the deliverable is making its job in the target, and that really, I think, and we have a risk and a challenge that too many studies giving confusing data, and then the momentum can easily like in anything else in life in our society, you get a big momentum, and then 2 years later, this is a disaster, and let's move on. And so I think there is a responsibility, and I hope the FAST Foundation does intervene in this, trying to help to get the field into the more conscious and scientifically driven manner, I think, before we kill our golden thing.
I agree, and I'll just make just a couple of comments to follow up. I agree with everything that's been said so far, but my simplistic neurosurgical brain, the way that I sort of view things is, there's an opportunity to enhance the things that we've been doing in neurosurgery for many, many years, which is generating lesions in the brain. And focused ultrasound allows us to do that in a new, safer, and what we're looking for there is as effective, not necessarily more effective, but as effective as lesions in the brain, but doing it in a safer way, because that in and of itself is going to lower the threshold for referral and for interest and for people to get involved with this. And that's where the thalamotomy and the paladotomy and the subthalamotomy and the capsulotomy work comes into play. So this is a new, a significant tool that allows us to do something that we haven't done before, that we've done before, but in a new way. Now, there's that other realm of using this as an entirely different tool, which is a drug delivery strategy and a neuromodulation strategy, and looking at the myriad mechanisms that focused ultrasound brings brings to the fore there. So I agree that we need to move the field forward in parallel in terms of technical developments, shaveless, pinless, making enhancing tolerability of the procedure, which has broad applications not only for males and females, but gender, but age groups, etc. Going all the way from pediatric to older patients, just making it a much more feasible and tolerable procedure. And then there is the investigations that go into using this as proving that this can be used as a wholly different approach to treatment-resistant neurologic and psychiatric conditions. And that in and of itself is a whole other area where I agree with Reese, is really where the excitement is in focused ultrasound, using it as a novel tool to really address some conditions that in the past were not even neurosurgical diseases, but now have become diseases where we're approaching it with neuromodulation. So I share the excitement and also the call for additional work, additional science that's judicious and that really tries to get at these answers.
Well, thank you all so much for participating in this panel. I think this was a great discussion. And I wanted to thank everyone online for joining us. This concludes today's briefing. If you have any additional questions that you think of or would like some additional information, please visit our website at fusfoundation.org or email us at info@fusfoundation.org. And again, I just want to thank you all for joining us and have a wonderful day.
Bye.
Thank you so much. Have a good day.